All right. Hello. Good evening, everyone. If you are joining now, you are joining the GeneSight Engage webinar. You are in the right place. We are starting 1 minute early to let people trickle in, and we will start promptly at 7 p.m. We'll give people a moment to join. All right. A few more seconds here. All right, it is 7 p.m. We are going to go ahead and get started. Hello and welcome to the second webinar of a series designed to expand upon how to appropriately use GeneSight beyond the green, yellow, and red bins. My name is Dr. Rachel Earls, and I will be your moderator this evening. Please direct your questions into the Q&A feature. If you have any tonight, the chat feature is disabled, so please put them in the Q&A, and we will do our best to answer as many questions as we can during the webinar. We will follow up this webinar with a recording that is available if some of your questions did not get answered. And if you have any follow-up questions, please feel free to reach out with us following the webinar at GeneSightEngage@genesight.com. In our previous webinar, we discussed the different sections of the report. So the green, yellow, and red section, which is called the interpretive portion of the report. We looked at the genotype and phenotype section. We learned about what the gene-drug interaction chart is. And we reviewed, importantly, how to appropriately use the clinical considerations seen on the GeneSight report. And we were so thankful because we received dozens of great questions during the previous webinar that we plan to address tonight, as well as talk to our panel of expert GeneSight users on their experience in utilization and implementation of the GeneSight test in their practice. Some of the topics we're going to touch on tonight is what does it mean if a medication's in the green category? Why may I see some medications there more commonly than others? How does smoking affect my patient's GeneSight results? Will your patient's GeneSight results change over time? And we got a great question about, are there studies that have assessed the clinical utility of GeneSight in patients with major depressive disorder? And we're very excited to share some brand new data that is from a multi-year study, a real-world study of over 21,000 patients with major depressive disorder, investigating healthcare utilization following the use of the GeneSight test. Briefly, before we begin, I would love to introduce our expert panel of GeneSight users. First, we have Dr. Carson Felkel, who is a psychiatrist, as well as a distinguished fellow of the American Psychiatric Association, the systems medical director at Bon Secours Mercy Health in Greenville, South Carolina. Welcome, Dr. Felkel. Great to see you.
Thank you. Glad to be here.
Next, we have Dr. Ann Groover, a board-certified psychiatrist, the owner and medical director of the Groover Clinic in Georgia, an associate professor of psychiatry, and the psychiatry clerkship director for Medical College of Georgia Northwest Campus. Thank you for being here tonight, Dr. Groover.
Thank you for having me, Rachel. I'm excited to be here.
And we have Dr. Bernie Ranchero, who is a primary care clinician who also obtained his MBA and is currently the medical director of the Hospital Sisters Health System in Charleston, Illinois. Thank you for being here again, Dr. Ranchero.
Thank you.
Let's go ahead and get started. So to begin our conversation, I would like to ask each of the panelists, why and how do you utilize the GeneSight test? So Dr. Groover, I'll begin with you.
Well, I began using the GeneSight tests really almost by accident, because we had an elderly gentleman come in with a great deal of medication toxicity. And it just happened that one of the GeneSight reps had been in my office that day. And I thought, well, maybe this is a situation where I can figure something out. So we ran the test, found out that he had a very complicated set of 2D6 slow metabolism and was on many medications that were affected by this. It turned out that his dementia was not actually dementia, but was toxicity from his antipsychotic, and his inability to walk was also coming from that toxicity. So we were able to get him on appropriate medications and off of the medications that were giving him terrible, terrible side effects, and get him back to functioning and out of the nursing home. So it was really an amazing situation, and pointed out to me how important it was to know that individual information.
Wow, that's very powerful. Thank you for sharing. Dr. Ranchero, how and why do you use the GeneSight test?
Well, for me, it was being a primary care physician. And obviously, it helps me make decisions. Simple tool in the chest. How many times do we have patients that come in with comorbid conditions? And what really needs to happen is that I need to address their anxiety, their depression. I need to address their psychosocial issues first. And oftentimes, I'm taking a guess. I'm taking a stab in the dark of, okay, let's start you on this. I hope it works. And if I can have a tool that better helps me assess which is based on evidence, and which I can tell the patient and show the patient that, hey, I'm making an educated decision here based on your genetics, based on your the medications, based on the pharmacokinetics and the pharmacodynamics, and how that's going to affect the patient, then I get better buy-in. And also, this is, if I'm being very proactive, this is a way that, hey, before I start you on a medicine, how can I proactively get you on the correct medicine? Or, I tried you on several medications, or past providers have tried you on several medications, and how can I make a better educated decision to see why those medications maybe haven't worked for you, and to get you on a better medication?
Thank you. One question I have, so it sounds like when you use GeneSight depends on the patient.
Yes, that is a great question. And there are times now that I'm more familiar with GeneSight, I'm more proactive, and that I can use the GeneSight test proactively even before I start the medication. But oftentimes, when patients come in to see me and they're in distress and they're suffering, oftentimes we start a medication. And then if that medication doesn't work, the evidence does show, then go to GeneSight to make sure that we can make a better choice going on in the future, so that we're not getting on this merry-go-round of which medicine to try and to hop on and to hop off of.
Thank you. And Dr. Falco, same question for you. How and why do you utilize GeneSight testing?
Thanks, Rachel. I was a bit of a slow adapter, and it took me having another psychiatrist get my patient well for me to jump on the bandwagon and learn more about it. The more I learn about GeneSight, the more I realize there's still so much more to learn. The test is such a layered panel of information and an evolving science. But one day, this patient came in with OCD and depression, a young 14-year-old boy, and I was unable to get him well with my go-to of Prozac and Zoloft, even Abilify and clomipramine. And low doses seemed high. He had more side effects than other people did. And he was on homebound, so I felt like I had this urgency to get him into remission. And it unfortunately was another psychiatrist who found the right medicine based off of the GeneSight. And so that got me learning more. So happy to be here.
Thank you so much. So I'm going to go ahead and share my screen because I would like to pull up a sample report. So we'll go ahead and share this. We got a lot of questions about the report itself on the previous webinar. And so some of the questions were surrounding are you able to see the sample report?
Yes.
Yes.
Okay. Some of the questions were surrounding what does it actually mean when a medication is in the green? And so I know if you're on this webinar, you're likely familiar with the organization of the GeneSight report, but when a medication is in the green, what does that mean? Genetically speaking, it indicates that there are no variations found in your patient's genes that are expected to impact their outcomes to that medication. However, Dr. Ranchero, I'm interested in what it means to you clinically when you see a medication is in the green category. How do you interpret that?
Sure. I think one of the things, for instance, if this is my patient, I look and I say, well, this is why when I start him on Lexapro, escitalopram, which is usually my go-to, or Zoloft or sertraline, I can look and say, oh, wait a second. There's some significant gene-drug interactions there. That is perhaps why they didn't respond, or perhaps they had side effects, or perhaps they didn't do well on those medications. It's also a way to show the patient, this isn't your fault. This is your genetics. This is your genes. You don't blame your parents. And so then, my go-tos are, which we all have go-tos, are generally Lexapro and Zoloft. And so I look and I say, oh, I've tried those two, and this is why they didn't work out. And then I could look at the green section and say, there's no significant drug interactions there, interactions there. And I can say, you know what, based on your genotype, based on your phenotype, I think one of these medicines in the green would be good for me to pick for you. And I can say, and then I can also say to insurance companies and say, based on these gene drug interactions, one of these medications would be best for you. So for instance, I might look at it and say, oh, okay, in the green section, there's desvenlafaxine, there's Trintellix, there's other medicines that we can try that would help that patient to have better outcomes and to better control, say, their depression, say, their anxiety. And so looking at that, and that doesn't mean that I might look at bupropion and then I look at clinical considerations. Serum level might be, it's 2 is the note on there. Serum levels might be too low, higher doses might be required. Okay, so it doesn't mean that I can't use the red, but it means that there's some clinical considerations there where if I look at the green, I can say I can use these medicines confidently, knowing that I can use them as directed, I can titrate them as directed, and hopefully that also puts in my patient's mind that, wait a second, based on my genes, I can have a tailored medication given to me that will help my depression, that will help my anxiety. And so I might, like I said, if I tried them on sertraline and escitalopram before, I might look and say, oh, well, I can try desvenlafaxine. Let me try that one. Or now, by the time that they've gone through 2 generic antidepressants, then maybe I can try Trintellix. So it gives my patient and it gives me an option to do that shared decision-making where the patient can take ownership of their medications and of their disease state.
Thank you. That's very insightful. And I think what you described is the scenario we all hope for, that you see a medication in the green that meets the clinical need of your patients. But that's not always the case. And so I want to ask Dr. Gruber a question of how do you proceed if you're looking at the green category and you don't see a medication you would typically prescribe, or you don't see a medication that meets the clinical need of your patients? We get a lot of questions around, what do I do if I don't see a medication in the green that I feel meets the need of my patient? And Dr. Gruber, I'm so sorry, you got muted. So you're going to have to unmute. There you go.
There you go. It does come up actually quite often because being in an underserved area for psychiatry, patients usually have quite a few medication trials before they get to my office. So when I take a good medication history, often I've been able to check off, didn't tolerate this one, this one didn't work. So I have a list of medications that have already been tried. And it happens a lot that I'll get a report and most of my selections in the green have already been tried and failed or had some intolerances. So I think it's important to remember being in the green means use as directed, and that we don't have any drug gene interactions that direct us to use it differently. But it doesn't necessarily tell us that that medication is going to be tolerated by that patient or that it's going to be successful. Often have to look at the yellow group of medicines and be informed by the clinical considerations and say, okay, well, this medication has a moderate drug gene interaction, but I know what it is. I know that they're a slower than normal metabolizer or a faster than normal metabolizer of that medication. That informs my use of that medication so I can have a better chance of being successful with that and avoiding problems, avoiding toxicities. So I rarely select a medication that's in the red category. I can think of one situation where I had a patient who wasn't doing well. We switched around things really according to the GeneSight report, tried some different things, and we ended up going back to the red medication with dosage adjustments that were pretty dramatic. And that is where we ended up, was with a medication in the red. But almost always, I'm ending up with a medication in the yellow or the green when I'm having a good success. Sometimes we have to work our way toward that, though. We still may have some trial and error, even with the report in our hands. I can tell you after 10 years of doing GeneSights now, I have a lot less trial and error than I used to have. because this informs me about that individual patient's needs and their individual makeup. I find that the patients have a little more patience, if you will, with the process, because I can show them a reasoning in black and white, or in yellow, green, and red, if you will, why that I'm making certain selections or avoiding things that they may have said, oh, I heard this would be a good medicine, or my mom tried this, or my neighbor tried that. And, they're asking about something specific. And I'm like, well, that might be a good idea, because it looks like there's no reason for us not to try it.
Right.
Or I'd rather avoid it because of this. So I think the patients typically are willing to work with you even more, knowing that you've taken the time and the effort to find out this individual information about them. So it really informs my decisions.
Thank you. That was so insightful. And I think such an important takeaway of that. You can use medications across categories, and you should not feel like you are, have to pick from the green category. So thank you for sharing that. A question that we got a few times on the last webinar is, why do you see some medications in the green categories more than others? So I'm going to turn this one over to Dr. Felkel. We get an example that we hear sometimes is desvenlafaxine or Pristiq. So can you shine some light on maybe why we may see those medications in the green category more, Dr. Felkel?
I can sure try to. This is a really interesting case sample report. And you can see that the number 4 is everywhere. And so that's our indicator on the depression panel that there's a problem at the SLC6A4 serotonin reuptake protein. And so just in thinking through choice of med, like I have no problem using any of these medicines. And let's say it's in the pediatric psychiatry world, maybe I want to use Prozac. It's someone who I kind of want to activate just a little bit because they have this sluggish depression, not really motivated, poor adherence history. So I'm thinking Prozac. Prozac has a 1 and a 4 by it, so the dose might be a little bit higher. So not a big deal. Instead of starting 20, you might start 10, but it has that 4 by it. And that 4 indicates that serotonin gene problem. Just as a caveat, when you get to the stimulant, non-stimulant page, the 4 doesn't mean the serotonin gene problem. It means the ADRA2A gene problem. But so because there's a serotonin issue, you can see that the SNRIs are in some way being prioritized. And so Pristiq, being the active metabolite of Effexor, venlafaxine turning into desvenlafaxine, it's bypassing that problem. So naturally, it's going to be more likely to be in the green. It also, unlike Effexor, bypasses 2D6. And so because 1 in 5 patients have a problem at 2D6, then Pristiq, desvenlafaxine, frequently is in the green. That can indicate a problem at 2D6, but in this case, there's a problem at 2C19 and 2B6. This doesn't, though, Rachel, mean that Pristiq is the right medicine. It means that there's no known gene-drug interactions, like you said, but it mainly goes through 3A4. And if you can't remember all the pathways, you just have to go to the dotted bubble pages at the end, and you can go look up. Yeah, thanks for pulling that up. You'll look to the green, and you'll see that it goes through, go back one. It goes through 2C19 and 3A4. Now, I'm learning that perhaps 2C19 doesn't have as big of an impact on Pristiq. It's mainly 3A4. So, but just because it's in the green doesn't mean it's right, because you might be on a 3A4 inhibitor. For instance, that pesky grapefruit juice that everyone knows inhibits 3A4 could phenoconvert this person and actually boost up the levels of Pristiq. Or perhaps ketoconazole, or perhaps they're on a 3A4 inducer, which is Tegretol, carbamazepine. So you can't necessarily just take this at face value. You have to know what other medicines they are on. It is unlikely, though, that the patient has a problem at 3A4. 91% of patients are extensive normal metabolizers at 3A4. But I'll tell you, Rachel, I've seen a whole lot of intermediate 3A4 metabolizers lately. It's only 9% of the population, but I've been seeing a lot of it. And that, of course, would change the results.
Thank you. So the summary, I think, of that answer there is it depends the metabolic pathway of the medication. Some of the genes are more prone to variations than others. And if those medications run through those pathways, they're more likely to be affected and maybe placed in the yellow or the red category. But to echo everyone's sentiment here, green does not mean it will work for your patient. I mean, genetically, it is an optimal choice, but there are many factors that go into that selection process. So thank you for sharing your wisdom on that. I think that's probably one of the most important things that people need to understand when using the report. We also got a lot of questions on an upgrade that was done recently that looks at the effect of smoking on a patient's GeneSight report. So recently, the GeneSight Psychotropic Report added an enhancement that accounts for how a patient's smoking status may affect the metabolism of certain medications. And so I wanted to touch on that, what that upgrade was, and then we can talk to our expert panel of clinicians to talk about how they think about this when prescribing. So you'll notice that on 3 of the classes of drugs on the GeneSight report, the antidepressants, anxiolytics and hypnotics, and antipsychotics now have 2 pages on them. Page 1, there's this big box here that's labeled non-smoker, and then there is a smoker version. Same thing with anxiolytics and hypnotics, non-smoker, smoker, and the same for antipsychotics. And I want to explain why that is the case. So if you see this on your patient's GeneSight report, what this means is your patient has a variation in a metabolism gene that we look at on the report. It's called CYP1A2, CYP1A2. If a patient has the inducible version of this gene, which approximately 91% of GeneSight tested patients do, so it is quite common, if they have this variant, it means that smoking can impact how they metabolize medications that run through that gene. If your patient does not have the inducible version of the gene, I am going to show you what your report will look like. It will look like this. It will tell you that the results, this section shows the results for non-smokers and smokers because they don't have this highly inducible variant. But more likely than not, you will see the version that looks like this because this variant is so common. So this update highlights how smoking and environmental factors can actually affect the metabolism of certain medications, and how knowing your patient's smoking status is integral to prescribing medications, because you will see that the binning looks different on the smoking and non-smoking pages. So let me go ahead and full screen here so we can see this. So this will affect the binning of medications, knowing your patient's smoking status. We define smoking at the smoking pages on the top of the report. It's defined as the daily inhalation of burning plant material. So it's actually the burning of the hydrocarbons that are found in that plant material. So that's why it excludes things like vaping and e-cigarettes. And this is used to determine how medications will be binned if a patient is a smoker. So Dr. Falco, we'll start with you. How has this recent change to the GeneSight report affected your medication selection process and really your thought process behind selecting meds for your patients?
Significantly. If you will just go back to that first page, Rachel, it's a good reminder whenever you see the 7, how many of our medicines are impacted by smoking, and really good ones like Cymbalta, mirtazapine, Luvox, clomipramine. If your patient, you ask them if they're smoking daily, then you need to use the other side. And if you'll go to that page, you'll see that now these medicines are in the red with a 2. And so the blood level will likely to be lower because they've now induced that 1A2 gene. As an aside, Wellbutrin was already in the red because 2B6 is ultra rapid. That does not have to do with smoking. And so you can glean that information deeper in the report as to why there's a difference in them being in the red. But one last point, Rachel, because a lot of us take care of patients with mood disorders, psychotic disorders. If you'll just go to the antipsychotic page, and let's say we're trying to stabilize someone by bipolar 1 manic episode or patient with schizophrenia, look how many of our very important antipsychotics are inducible by 1A2. Some pretty important medicines, olanzapine, Haldol, clozapine. So then if you go one more, Rachel, let's say they are smoking every day, you again will see how they've been shifted to the red or yellow with that 2 next to it. We have to ask about smoking. And if the patient says, I don't smoke marijuana, I just use gummies or edibles, it is important for you to continue to monitor this emerging field that a lot of those substances actually do still inhibit some pathways like 3A4 and 2C19. So our blood levels actually could be higher of medicines, not the opposite here of being lower.
Thank you, Dr. Falco. Dr. Groover, I'd like to know any thoughts or experiences you've had with this recent update with the effect of smoking.
Absolutely. I have probably redone and updated more tests previously done because of this smoking update, because it really does. So many of our patients are smokers still. And even in the process of trying to treat them, they start out smoking and at some point they try to stop smoking, or they may switch to the patch, or they may switch to the gum, or they switch to a vape. So we were medicating them based on the smoking status at the beginning, and they change, try to quit their smoking status, and really all of your choices go up in the air again. And you have to kind of rethink what's going on, because you might be prone to relapse because of changes in drug levels, or prone to toxicity because of those changes. So I have done a lot of updates of reports that were prior to this new report version in order to sort that out for some of my folks.
Thank you. Dr. Ranchero, same question for you. So thoughts or experiences on how this has affected your use of GeneSight?
Well, from a primary care standpoint, obviously one of the things that we need to address in the patient's overall health is the smoking status in itself. And oftentimes that can bring up an initiation to say, are you interested in stopping smoking? And if that's probably one of the best things you can do in terms of your general health. And one of the things that I want to touch back on it before is when you're picking these different medicines, especially in primary care, oftentimes we are concerned about, is this going to affect the patient's weight? Is this going to affect the patient's sleeping? Is there other things that we can use these medications for, such as which ones can we use to treat headaches? So oftentimes the smoking status is one component, but knowing that we can continually upgrade, and GeneSight continually upgrades their reports, is amazing for the patients. And the fact that it's done free of charge, and letting the patient know that, you know what, this is a living document that you don't have to pay for and will get upgraded at no charge. And the fact that we know that smoking, as both Dr. Groover and Dr. Falco went into, it affects our patients and over the overall general health. So the fact that it breaks it down makes it even more specific and more tailored for the patient.
Thank you. One follow-up question, something that kind of sparked my thought that you said, how do you explain this to patients? Do you tell them that, smoking can affect how they break down medications? How do you have that conversation?
Smoking affects everything. That's what I tell patients. Smoking, if they can choose one thing in their life to improve their health, and if they were to ask me, is it losing weight? Is it getting my blood pressure under control? Is it getting my cholesterol under control? Is it treating my depression? When it comes down to it, smoking is one of the best things that you can do to improve your overall health. And oftentimes, if I need to, and asking the patient, what do you get out of smoking? All right, if I can help you with your stress, if I can help you with your anxiety, if I can help you with your boredom, your anger, can we consider smoking cessation? So that's where I think this is also powerful in letting the patient know it's not just about treating your depression, your anxiety, your bipolar, your schizophrenia. It's about your overall health. And this is how smoking even affects medications and your genes.
Thank you. All right, I'm going to stop sharing my screen here. One question that we've gotten quite frequently, and I'm really excited to talk about it. is regarding, will my patient's GeneSight report change over time? Will it be accurate over the life of the patient? And so I'm going to start by answering this question from a scientific perspective, and then I'm going to turn it over to our panelists to discuss when and if they choose to upgrade a test. So you kind of heard them hinting at the upgrading process throughout this webinar. So I'm really glad we're going to chat through this. So from a genetics perspective, your patient's genes do not change over time. So therefore, the results shown on the GeneSight report will not change. However, it is possible that as the science of pharmacogenomics continues to evolve, that we can make enhancements to the test. So one of the enhancements we made is one we were just talking about, the smoking enhancement. So if you feel that an enhancement made to the test can help your patient clinically or provide you more information to help with that patient medication selection, you can upgrade your patient's GeneSight test at no cost. So the patient will have to be re-swabbed because we don't save those in our lab, but there will be no charge to upgrade. And this just speaks to the evolution and growth of the field. As new information is discovered, we make scientific enhancements that follow the data. But in terms of an accuracy, your patient's genes will not change over time. So Dr. Groover, I'll start with you. When do you choose to upgrade a patient report?
Yeah, as I said, when I have someone who has the highly inducible variant, I'm upgrading a lot of those reports now just because it really does bend the medications quite differently. But also, I've had some reports done 10 years ago now. So it's really a lot of medications have come out to treat psychosis, to treat depression. So there have been a lot of medications added to the algorithm that we didn't have before. And sometimes if the metabolism of that medication is reasonably simple, I feel like I can extrapolate from the old report where it would been. But really, the algorithm is very elegant and quite complicated because most medications are affected by more than one enzyme. So if somebody has a report that's normal in all ways except for one, I can maybe think I know where that would go. But most people are a little more complicated than that. So I like to go through, let it plug through the algorithm as it's updated and give me a fresh look at where those medications that hadn't been available before would pop up.
Thank you very much. Dr. Ranchero, how do you discuss a potential upgrade with your patients? Since it does require a new swab, what does that conversation look like when you're thinking about upgrading a report?
And usually, obviously, there is a reason that I'm looking at the report. Are they not, what medications are they taking, and what's going on in their lives that things have changed? And then also letting the patient know that, hey, yes, your genetics have not changed, but science does change and more data is available on their new medications. And letting the patient know also, especially with the smoking, we know it takes the average person 7 to 9 times to quit smoking. And so that status changes and is often very fluid. And so sometimes just upgrading that smoking status part is very important to let the patient know, hey, look, now that you started smoking again, or now that you stopped smoking, we can make some other considerations. So I think that's why GeneSight is so powerful in letting the patient know that it is a living, growing, and changing document that we can upgrade. And just because something changes, their genes don't change, but the science does change and evolve.
Thank you. Appreciate that. Dr. Falco, anything else to add there?
I think it comes down to what is being upgraded, and I just really appreciate the addition of the CES1A1 Ritalin gene, ADRA2A coming back, and the COMT COMT gene, all very helpful in making clinical considerations. And so when new genes come about, I'll upgrade.
Thank you. And I would be remiss not to share that you may have noticed when I had the report up, on the top right of every page is a 1-800 number and email address. That's for our medical team. So our medical team is a team of MD, PharmDs, and PhDs who are available on call to you as healthcare providers. So if you have questions about genes on the report or genes not on the report or anything about the scientific nature of the report, that's what that team is there for. So if there's some genes that you're like, oh, I wonder why that one's not on there, we have white papers, we have response documents, we have people who are answering the phones to help with those questions. So please use that resource. That is what we're there for. We can also be contacted on the GeneSight.com website under the medical affairs page. So please use that resource. That is why we are here. The last webinar, we started receiving questions surrounding if patient outcomes have been assessed when utilizing the GeneSight Psychotropic Report. And I'm going to go ahead. I apologize for the sharing and non-sharing madness here, but bear with me. I want to share my screen because I want to talk about this. So thumbs up, we can see the slide.
Yes.
Awesome. Okay. Thank you so much. So what you're looking at here on the left is a table that shows the summary of GeneSight clinical evidence that exists. So let me go ahead and I wanted to display this table. I'm not going to go into details of all of these studies. We don't have time, but I want to show that the clinical utility of GeneSight has been assessed in comparison to the standard of care. We also call that treatment as usual. So there's been many studies that have been conducted that look that if a provider has access to GeneSight testing, does this lead to better outcomes compared to the standard of care? So both arms in these trials are receiving active therapy. The main difference is that on they call the guided arm, those patients' providers have access to this testing to help with this. And there are numerous trials that have been conducted that have shown that there is clinical utility when this tool is available to the provider. GeneSight also just is the most studied pharmacogenomic test in the mental health space, and our test has been a part of the 2 largest randomized control trials looking at the utility of pharmacogenomics in major depression. So I just wanted to let you know this information exists. Again, if you have any questions or want more information on this, please reach out to your medical partner. That is what they're there for, to talk through this, what the studies have shown, what they haven't shown. So please do not be shy and ask questions about this because we like to talk about it. I also mentioned in the beginning of the webinar that we are going to talk about some new real-world evidence from a data set of over 20,000 GeneSight patients tested with MDD. So this was a real-world study of healthcare utilization for GeneSight tested patients with major depressive disorder. And what this study did was it evaluated the proportion of major depressive patients prescribed medications with significant gene-drug interactions before GeneSight testing and after. So I wanted to address if GeneSight testing is available, does this lead to a reduction in number of medications prescribed with known genetic issues? We also wanted to investigate hospitalizations pre and post GeneSight testing. So when GeneSight testing was brought on board, did that affect hospitalizations for these patients with major depression? This was a claims data set that had about 20,933 GeneSight patients with major depressive disorder, of which 16,965 were taking medications. Just a little bit about this trial, just to give you a little bit more insight into what these patients were like. To be in this study, you had to be 18 years or older. The GeneSight test had to be in the claims database that we looked at. The patients had to have medical and pharmacy coverage between January 1st, 2015 and September 30th, 2021. And they had to have medical and pharmacy coverage on the index date, which basically the index date is just the date in which the healthcare provider was granted access to the GeneSight test. They had to have continuous enrollment about 360 days prior and 180 days post the index date, so post GeneSight testing. And they had to have at least one medical claim with an ICD-10 code for major depressive disorder. They were excluded from the trial if they did not have ICD-10 code for major depression, or they were missing demographic data, missing region, or had an ambiguous test version. What was found, so what I'm going to orient you to here is this is on the left, the 90-day baseline. So this is prior to the GeneSight results being shown. And then the 90-day follow-up is after the index date. So 90 days after the provider got access to the GeneSight test. These different colored bars here match the different green, yellow, and red buckets on our report. So green means no gene-drug interactions, yellow means moderate, and red means significant gene-drug interactions. On the y-axis here, this is percentage of patients, and then here are our 2 groups. So prior to GeneSight testing on the left, following GeneSight testing on the right. And what you see at baseline, 90-day baseline, that about 27.5% of patients were on medications with no gene-drug interactions. But we had about 46% of patients on medications in the yellow and 26.1% of patients on medications in the red. And what you see following GeneSight testing is that there was a decrease in the proportion of patients prescribed medications with known significant gene-drug interactions. So what this tells us here is that when providers have this as a tool, it does decrease the proportion of medications that patients are receiving with these genetic issues. We also saw a significant reduction in the percentage of patients with hospitalizations following GeneSight testing. So these two different colored blue here, so the light blue is a 180-day baseline, and then the 180-day follow-up following the index date, so following GeneSight testing. So kind of think of this as pre-GeneSight in light blue and post-GeneSight in the dark blue. And on the x-axis here, we have any type of hospitalization, psychiatric hospitalization, and non-psychiatric hospitalizations. And on the y-axis, this is a percentage of patients with hospitalizations in this claims data set. So what you can see is after GeneSight testing, there was a significant decrease in any hospitalization. So a 29% relative reduction in hospitalization for these patients following GeneSight testing. However, when you break this down of psychiatric versus non-psychiatric hospitalizations, you see that the bulk of the reduction is coming from psychiatric hospitalizations. So there was a statistically significant reduction, relative reduction in the amount of psychiatric hospitalizations following GeneSight testing. So we see a 39% relative reduction here, and we do not see a significant reduction in other non-psych hospitalizations. So again, what this tells us here is following GeneSight testing, there was a significant decrease in the percentage of patients with psychiatric hospitalizations. And this was a real world claims data set. And so this was a kind of a new type of data that we looked at to see in the real world, does this have an effect on healthcare utilization? So I am going to turn it over to our panelists who you came here to see, because I would like to chat with them about, what does this data mean to you? So Dr. Ranchero, when you see this data, how do you perceive it? What does it mean to you?
It gives me the evidence and the confidence that, number one, I'm making the right decision in by offering this testing to patients and giving them the ability to make better healthcare choices based on their own genetics and based on their own genes and based on the medications they're on. And of course, when I'm very fortunate being in primary care that I'm catching patients early. I'm not catching patients that are in urgent need of psychiatric hospitalization. I'm catching patients when they're in mild distress because my nurse is asking every single patient a PHQ-2, and then it goes on to a PHQ-9 if they're positive in the PHQ-2. So I'm very fortunate that I'm catching patients early and proactively catching patients. Unlike our esteemed psychiatrist panel here, is that oftentimes they're seeing the worst of the worst patients that have had numerous psychiatric hospitalizations. But I'm catching patients early. But it gives me the confidence that when I tell a patient, you know what, this medication hasn't seemed to work for you, for your depression, for your anxiety, for your bipolar. Why don't we GeneSight test you, which is an evidence-based way of looking at your genes and seeing how the medication is affected by your genes and how the genes are affecting the medications. And then also asking the patient, there's some cost to this. Most likely insurance will cover it, but I'm also being preventative and being proactive and saying, you know what, if you can wait, if you want to wait to start medications, if you're doing okay for now, or you want to do counseling or do some other modalities to treat their condition, then maybe we can wait 3 to 4 weeks to get this data back and come back and decide together which medication is best for them. So with this, I mean, an N of 17,000, how amazing is that to say that we now have the data to show that GeneSight does reduce financial burdens, financial costs, and suffering, psychological and psychiatric suffering of our patients.
Thank you very much. And I really appreciate your perspective as a primary care provider, how this data looks to you. So Dr. Groover, would you like to go next?
Sure. I really appreciate the fact that GeneSight has been studied this way, because it really validates my clinical experience in the office with what I am seeing. And that is, when I use the GeneSight information, I get globally better results in terms of my patient population. And also, this particular study shows reduced hospitalizations. And certainly in my experience, I see reduced problems with toxicity. As I mentioned in my first example, when we don't know that someone's a slow metabolizer of a medication and we dose it normally, we can run into some serotonin toxicity problems, dopamine toxicity problems. We can see all kinds of issues. And being able to reduce hospitalizations in patients who are already suffering quite a bit with their mental health and also a lot of comorbidities medically it is the goal. We want to be as data driven as we can. So it's always nice to see a study that really reinforces what we've kind of experienced in the office based on our evolving practices.
Thank you. Dr. Falco, what are your thoughts on the study?
It's really good to see this data, because I think for a long time you all were talking about the Medco study just to show that how you could reduce the annual cost of pharmacy benefits for a patient. And now that you're tiptoeing, jumping perhaps more likely into cost data around hospitalization and outcomes. So really happy to see this. Sometimes I question, are we getting patients well with the right medicine, or are we reducing the side effects from perhaps the wrong medicine? And perhaps it doesn't really matter as long as we're keeping them out of the hospital and helping them to live a healthier life. I think the ability to reduce gene-drug interactions by moving away from certain medicines, allowing a patient to stay on a medicine, whether it be the best medicine or perhaps an okay medicine, just them being able to stay on it and tolerate it is probably a huge step forward, leading to these reductions in hospitalizations.
Thank you very much. I appreciate your feedback on this. I think this is really important data. The slides that I showed originally, the first slide, most of that data is in a controlled, randomized controlled trial setting. And so we wanted to see if the data we saw in those trials was mirrored in the real world. So we were very thrilled about that. I also want to talk about a question that we hear all the time, and it is a very fair question, but I am not the right person to answer it. So this question is around cost. So I want to take some time to discuss the cost of the GeneSight test. And in order to do this, I'm going to pull in one of our inside sales representatives, Tessa Kennedy. I'm going to share my screen. So Tessa, just give me 1 second to do that. And what I'm going to ask is, can you please explain how much the GeneSight test costs?
Yeah, of course. And that is such a good question. And as an inside sales representative here at GeneSight, I have the luxury of working with your patients. I don't know if everyone knew that was a tool, if they had any burden of answering these questions. I am somebody they can get in contact with. There's a whole team of us, but alongside of working with providers. So the cost for GeneSight is actually really simple. So I love to start off and say that majority of patients pay $330 or less. And there are insurance types where actually your patient would have no cost at all. Those insurance types are our Medicare patients, our Medicaid patients. But if they happen to fall under that commercial private insurance type umbrella, we do work with all active insurance types, so they should cover a majority of our testing. But there are times where a patient can still be required to pay a portion of that cost. Typically, we see that around $330 or less. But I like to call out here too, for any patients worried, we actually have a GeneSight promise where if it looks like a patient could pay more than $330, we hold the process. We reach out to them many times to make sure they're familiar with our financial assistance system set up for them, as well as interest-free payment plans. So you'll actually see here on this, the sliding scale we have for financial assistance. Again, I work with patients and love to touch on that. A lot of patients who think that they wouldn't apply for our financial assistance program do actually qualify. We go up 4 times the poverty level based off a household income and number of people in the house. So we really do want to make sure that cost is not a barrier for your patients. Of course, we are working with patients with mental health and don't want any more anxiety or depression to be caused by this. Make sure that cost is not a barrier to them receiving these results. And so again, make sure that they reach out to us. Actually, within your collection kits, you are going to see this exact thing to be able to show your patients to begin with. All of this information to move forward to make a decision on cost, but also a number, or somebody like myself is definitely there to help talk with your patients to make sure that we can get them these results if needed. Something else I like to bring up too while we are talking about this, often, of course, once we file a claim with insurance, we do have an explanation of benefits that go to patients. I wish we could control that, but it's going to show them exactly what was filed with insurance. This is not a bill. A lot of our patients do think that it is a bill, but want to call out that the bill will come from GeneSight. It will have the GeneSight logo. And if there's any questions about that, they again can call someone like myself or our billing team. We're all here available to them to make sure that everything goes smoothly and that you all only have to worry about interpreting the results and we can handle all of that billing process. But ultimately, yeah, we are here to make sure that as many patients can get this as affordable as possible. I always like to think too, we wouldn't be testing almost 3 million patients now if we weren't doing right by the patient. So that is my piece. I'm happy to answer questions in the chat if you want to send any in, or get you in contact with representatives able to work through what they know of your area, your state, different insurance plans, and of course hear from Rachel if any of the panelists have any experience as well.
Yes, thank you. Thank you for that explanation, Tessa. We get questions on that all the time. We appreciate the increased clarity. And I wanted to talk to our panelists on your experience with billing. I think that's the most important thing is how has it been for you? Have you ever had a patient issue with billing? Dr. Falco, we'll start with you on this one and just work our way through the panelists.
Yeah, that was my largest concern with starting testing, but I have never had a problem. And rapport with my patients is paramount. It's never been damaged by an issue. And further, I work with a population who've been highly traumatized and human sex trafficked. They don't have Medicaid or another payer source. And so writing a letter in support of them getting GeneSight has always been approved and a huge benefit to this really hard to treat population. So I appreciate GeneSight.
Thank you. Dr. Gruber, what has your experience been with billing?
I have tried several genetic testing companies before I really settled on GeneSight as my go-to test. I had innumerable problems with phone calls from patients, getting bills, getting problems that they did not expect to get. So they didn't last very long in my office. When I started using GeneSight, that went away. And so I am always happy to tell my patients about that GeneSight promise. And so many of them are Medicare, Medicaid patients, and they have no copay at all. I love being able to tell them that. There's something here that really helps reinforce our doctor-patient relationship because I know they can trust the information I'm giving them. They're not going to hear anything from you guys that's other than what I told them they were going to hear. And so it's always been a very positive experience for me. You guys do what you say you're going to do.
Thank you. And Dr. Ranchero, what has your experience been with billing for the GeneSight test?
I think one of the most powerful tools is that you give us that GeneSight folder where the sample collection kit is, and then to hand that to the patient and show them that the most they'll pay is $330. And then letting the patient know that this is a very, very valuable tool and this is their information, and that they will have evidence and information that they can refer to for the rest of their lives. I think one of the things that you, Tessa, hit on was letting the patient know, especially the commercially insured patient, is that don't confuse the explanation of benefits, because sometimes that explanation of benefits will be in the thousands of dollars, and the patient thinks, oh my gosh, I thought Dr. Ranchero said it was only going to be, no more than $330, $300. And letting that patient know, and I've had to learn that personally, that sometimes patient calls back and said, you lied to me. You said it was only going to be $300. And I got this bill. And I said, well, it's not a bill. It's what GeneSight Myriad is charging the insurance company. You'll get a bill separately from GeneSight. So being more proactive also and letting the patient know, the commercially insured patients, and giving them that folder gives them the reassurance, the evidence that, okay, it's in writing, and that helps a lot.
Thank you. Another question that we got on the last webinar, cluster of questions surrounding this that I wanted to address today, is circumstances that can affect the patient's GeneSight results. So we talked about smoking, obviously, and how we put that on the report for providers to be able to see, but what about other special conditions? So the questions we got specifically were liver transplant patients or patients taking concomitant medications. So I will touch on the liver transplant bit of it, and then I will turn it over to our panelists to talk about drug-drug interactions and how concomitant medications may affect patients there. So liver transplant. The results for pharmacodynamic genes will be accurate for liver transplant patients. These genes create proteins outside of the liver that interact with psychotropic medications. So the pharmacodynamic genes will still be accurate for patients if they have a liver transplant. However, the results for the pharmacokinetic genes will not be accurate, since the GeneSight test analyzes the DNA from the patient's cheek cells, but the transplanted liver will contain DNA from the donor, not the recipient. Since the GeneSight test depends on the outcome, the integration of both pharmacokinetic and pharmacodynamic genes, the interpretive pages of the report, so the green, yellow, red, may not be used because the pharmacokinetics will be that of the donor. So a liver transplant patient should only consider having GeneSight if the benefits can be gained from the pharmacodynamic genes alone. There's a few other instances we were asked about, but I want to turn it over to Dr. Felkel specifically. Do you want to speak to drug-drug interactions and how they may affect a patient's genetic results?
Yeah, sure. In the same way that smoking can induce 1A2, certain medicines can induce other pathways or inhibit other pathways. An example I like to be aware of, since it happens quite frequently, is how Prozac inhibits 2D6. Paroxetine does as well, but probably used a little bit less frequently. In fact, Wellbutrin also inhibits 2D6, is why it's also being added in a special new medicine. So, but with Prozac, Prozac's going through multiple pathways, 2D6, 3A4, 2C9, and 2C19, but it's inhibiting 2D6. So in some way, it's inhibiting itself as well. But because it's basic, let's say someone's GeneSight shows that they're an extensive normal metabolizer at 2D6. Well, let's say you want to put them on propranolol, Inderal. A hidden gem on the GeneSight panel is within the anxiolytic page, Inderal, propranolol. We use beta blockers in psychiatry for maybe treating hypervigilance within PTSD, that sympathetic surge. Maybe if you treat athletes, maybe a golfer with shaky hands, social anxiety, performance anxiety, or perhaps your primary care tonight and using it for hypertension. Well, propranolol goes through 2D6 and 1A2. Because it goes through 1A2, you do have to ask about smoking also, but it's going through 2D6. And let's say you put it on with Prozac. So Prozac's inhibiting 2D6. It's going through 2D6. And now let's say the patient is a poor 2D6 metabolizer. That propranolol dose could be through the roof, perhaps leading to bradycardia or bronchospasm. So it takes time to learn all of these pathways, but again, use that cheat sheet at the end with the bubble page. See where the multiple meds are crossing through and where the potential problems are. Rachel?
Thank you very much. Anything else to add there, Dr. Ranchero or Dr. Gruber, just generally about drug-drug interactions?
I would say, that identifying those 2D6 poor metabolizers has come up so many times in my practice. And that combination, which we used a lot in the past, of Prozac and Risperdal, would become a real serious problem in those patients that were poor 2D6 metabolizers. So there are some very specific combinations that were kind of old school effective for a lot of people that I've not gone into without having a GeneSight to tell me that this person is a normal metabolizer.
Thank you very much. One other instance we got questions about is, what if my patient had a stem cell transplant? How will this affect my GeneSight results? So it is possible that a stem cell transplant can affect the results of the GeneSight test. Buccal swab samples from patients who have received a stem cell transplant may contain DNA from donor cells in addition to their own cells, which could influence the results. So if the patient has had a stem cell transplant or a bone marrow transplant, it would be best if the patient could rinse their mouth with water several times before collecting the sample. And this may remove some of the surface blood cells and allow our lab to obtain preferentially patient cells and likely discern the patient's genotype. Somehow it is 7:59 p.m. We have had an hour full of great questions. I know I'm looking at the Q&A now. I appreciate the questions that you guys have been answering. It looks like most of them have been answered. If you have follow-up questions that you want to know more information on, please, again, email GeneSightEngage@genesight.com. There will be a recording available on our YouTube page in approximately the next week or two, so you will be able to share this with colleagues. And I sincerely want to thank you so much for your time and listening and seeking out more information on the GeneSight test. And thank you to our panelists for your time and expertise. And I hope you all have a wonderful night. Thank you very much.
Good night. Thank you.
Thank you.
Good night. Thank you, Rich.